big question, triplets or doublets at relapse?
Triplets.
Anybody vote against that? Always triplets now. What about the Endeavour clinical
so I'm
trial?
not sure
Let's
if,
talk about the Endeavour clinical trial.
So I don't know if triplets apply uniformly in first or second relapse. I think that the data looks great with the Aspire, and I think that, yes, I agree that triplet therapies make sense.
So Aspire, for those who don't know, is triplet carfilzomib, lenalidomide, dexamethasone.
Yes.
Let me just spend a minute, Jatin.
Yeah.
I don't know if you have the figures at your fingertips here, but can you explain to the audience the Endeavour clinical trial? I think it's an important trial that we discuss.
So I think the Endeavour trial actually is, I think, a very important trial. And in that trial, they randomized patients to either carfilzomib and dexamethasone versus bortezomib and dexamethasone in 1 to 3 lines of therapy.
And the carfilzomib dose was not what's on the label currently for FDA approval.
That's correct. So the carfilzomib there was given 56 milligrams per meter squared on days 1, 2,
Which
8,
is
9,
twice
15,
the
16.
label dose, right?
It's twice the label dose, but I don't think that's quote-unquote high dose. That may actually be full dose therapy, and the label dose is actually suboptimal or subtherapeutic dosing. So I think it's important to, when you frame that and discuss it, it's not necessarily high dose, it's maybe potentially full dose therapy, and everything we've been doing so far has been subtherapeutic.
Right.
And so it's actually an important trial, because this is one of the first trials in myeloma that's actually compared head-to-head 2 drugs versus 2 drugs, which I think is really practice informing. I mean, I think we expect to see improvements with 3 versus 2 drugs, but from a practicing perspective, when you have a head-to-head comparison, I think this is rather powerful. And what they showed there was a significant improvement in progression-free survival from approximately 9 months to 18 months, almost a near doubling in the progression-free survival, which I think is really unheard of when you compare.
Any overall survival change? Yeah.
So I don't know if we've seen the overall survival changes at this point in time. But I think that's pretty important, because that now starts letting us get away from 3 drugs. So when you talk about progression-free survivals in the 18, 19, 20-month range, all of that's been previously done with 3 drugs. So now potentially I can get that 1.5 to 2 year progression-free survival with just 2 drugs.
Are there patients? So we all sort of voted, I would sort of put my hand up too, for triplet therapy.
Yeah. But this changes.
Who would get a doublet therapy? And let's, we could throw in maybe pomalidomide and dexamethasone as well. Like, who would get a doublet instead of a triplet therapy? If anyone.
Yeah, it's a great question. So I think it's a little bit different, because I think the 3-drug regimens with Aspire and Tourmaline, I think are very helpful. But I'm not sure if they apply to patients right now that are getting continuous Revlimid in frontline therapy, or after transplant getting Revlimid maintenance, that those 3-drug regimens and that data applies to that setting. So I think that's where the Endeavour data with carfilzomib dex, I think, becomes very powerful, because that does apply to patients who are progressing on len from first-line therapy. So I think that's where you can get some nice responses.
Does Endeavour, so I'll get back to you, does Endeavour change the trial? So carfilzomib dexamethasone sort of almost doubles progression-free survival. We don't know about overall survival. It increases response rate, but it is twice a week and versus once a week. So does it change your practice at all here in the United States? Or
I mean, I think
Absolutely.
there is some.
I mean, your group actually defined that 56 was the tolerable dose. So
Yeah, I mean, and we've even found that for patients who progress on 27, you can recapture their response by escalating to 56. And the advantage of doing that is you minimize cost as well as toxicity. So for those few patients who may have idiosyncratic side effects from cardiopulmonary point of view at 2027, you've saved the 56 for the future. But I think, to Jatin's point, it is one of the first times that we're seeing this kind of efficacy with a 2-drug regimen. But I think one other thing I think we have to think about now with the approval of Implicity or elotuzumab is sequencing, because Elo doesn't have single-agent activity, and it's going to combine with len-dex. And
so let's, because we jumped onto elotuzumab, so we're talking about a monoclonal antibody here that's targeting myeloma cells, right?
Correct, right. So, and it's because this is an early relapse setting, which is where this was studied, and the eloquent Dr. Lonial should speak about it.
We will in a minute. I just want to finish up with this Endeavour trial.
But I think the point of it showed improved len-dex with the addition of Elo, improved PFS, particularly also in high-risk patients there was a benefit. And I think if you don't use the elotuzumab when a patient has not progressed on full-dose len, we don't know what its role might be. And there were some significant PFS benefits that are not to be minimized. So I think, so in other words, what I'm saying is if you do RD-Elo, you could always go back to all of the other drugs that you've heard about, including high-dose carfilzomib.
So my question was really about whether Endeavour is significant within the U.S. market.
I mean, from my perspective, what Endeavour tells me is that if somebody is proteasome inhibitor resistant, going to the higher dose of carfilzomib can salvage those patients. It doesn't mean that I'm going to use the higher dose earlier in the course. It just means that I know I've got a PI I can go to that, for the most part, is well tolerated at the higher dose.
Let's move. Sorry, go ahead. Paul.
That's an interesting. I'm sorry, just real quick. That's interesting because we talk about using our most effective therapy. So if you have an effective therapy, you try and move that earlier.
But you
so
can't
here you're
partner
flipping
it.
it.
But you can't partner it. That's my issue.
one?
56.
But do you
can't
need to partner it though if you're already getting
Well,
such?
but so if you
I don't know if anybody's tested that hypothesis yet.
well, most of the combination trials have an MTD of 36. Right. So you know you can't go higher. So I mean, if you believe that there are multiple subclones in the disease at any given time, we're going to combination therapy. Why do you want to give a dose so high you can't combine it?
Jatin, if I may, I so agree with Sagar. I totally take your point, and I think what's so impressive about this is it tells you in practice that you've got more potent proteasome inhibitors that in the properly selected patient who has been prior proteasome inhibitor exposed, you can salvage them. But I completely agree, Sagar. I think 3 drug regimens and 4. I mean, your data support that. Your own work with RBD
For newly diagnosed, yeah.
Understood, but even in relapse, I mean, arguably in relapse, it's more important.
Well, I would say there are some patients who can't take IMiDs. I mean, not everybody can tolerate them.
True.
People get rashes.
That's
People have
true.
renal
That's
failure.
true.
Well, renal failure, you probably wouldn't want to use high-dose carfilzomib.
Yeah.
But so there is probably a market for doublet therapy in certain indications,
fair.
maybe in older patients too.
That's fair.